So I can ask you questions, right? So there's no, these are all real cases, and all of them have always been a little bit challenging. And I actually thank the organizers for asking me to do this, because it made me think about all the cases that I wanted to use for teaching. And I will use this many times in the future, and I never had a reason to put it together. So thank you for asking me to do this so I could put it together. So we can take as much or little time, because we can stop at any point when we need to. And they're imaging cases as well. So the first one is actually a case that we presented at the American Thyroid Association, and we stumped the experts. So it's okay, you can guess, it's a great case. And it's a real case. So this is a 24-year-old female who had a left 1.5 centimeter nodule on physical exam. She had no family history of thyroid cancer, risk factors for thyroid cancer. She had no significant past medical history, and her TSH was just below normal. So no ultrasounds yet, just a low TSH. So which study would you like to do first? Actually, this is not the case that stumped the ATA, it's case number 2. So she has a low TSH and a thyroid nodule, so should she have an ultrasound first or a radionuclide scan? Okay, good. Okay, so here's her scan. So she has a 24-hour uptake of 32%, and this is her scan. And remember, she has a left thyroid nodule. So does anybody want to interpret the scan in our very small group? Is this a functioning nodule, a non-functioning nodule? Here's the left anterior oblique. So are you all familiar with how scans are done? Are there any the people in the back? I don't know if there's any trainees. Is everyone familiar with how scans are done? Yes? Okay. So this is the LAO. So what next? Does she need an FNA? Is this a non-functioning nodule? What is this?
Looks like there's some uptake on the radial left side of the gland. So
Yeah.
maybe it has to be matched with ultrasound to see.
Yeah, so maybe it has to see. The problem is that all of you people probably know things. So this is, so basically this is where the nodule was sort of palpated, and this is the part that's functioning, and I think that's the important point. So hopefully on this side, you're used to this idea of exactly what he said. I'm sorry, what's your first name again?
Khurshid.
So what Khurshid said was you have to match the scan with the ultrasound, and that's the only way to understand this. So what I've shown you here is this is the ultrasound of her left nodule, and what you can see on her left nodule is there's the trachea, you can see the carotid, and here it is. What I'm going to do, you can hear me if I come over here, right? So what I've done is I've oriented the sagittal view in the anatomic way that you could line it up next to the scan. And so what you can see is that the solid part of the nodule is in the superior lateral aspect, right over here and right over here. And we know that so that if you were to do a left anterior oblique view, and the solid part is in the superior lateral aspect, when you do an anterior oblique view, that's when the solid part moves medially. So this absolutely corresponds. So what she has, in fact, you can even see over here, there's a second solid part down here that corresponds to this area, and the only area that's not functioning is the fluid. So that, of course, this was labeled by the radiologist as having a cold nodule that she needed a biopsy for in her left lower pole, but what she in essence has is a functioning nodule of cystic degeneration. So the purpose of this case was really to highlight the point that there are many times that you cannot interpret a scan without knowing the ultrasound. Okay, and it sounds like I'm preaching to the choir here. Okay, so this is the case that the ATA had trouble with. So this is a 33-year-old female. And at age 17, she had Graves' disease. So 16 years ago, she had Graves' disease. She was treated with methimazole for 19 months, and she became euthyroid. And then at 28, so 5 years ago, she had a right upper pole nodule that was aspirated and was benign. And now, so 5 years later, she has some symptoms that are anxiety and weight loss and palpitations and heat intolerance. And her physical examination shows no thyroid-associated orbitopathy or thyroid-associated skin findings. So it's normal for thyroid-associated autoimmune physical examination findings. But her right upper pole has a 3-centimeter palpable nodule, and it's mobile, and she has this tremor of her outstretched hands. And these are her TFTs. So her TSH is undetectable, her free T4 is elevated, and her total T3 is elevated. Okay? So next step is going to be which radiology test? A scan? Okay. So here's her scan. So here's her TFTs, and here's her scan, and I've given you the whole screen capture of the anterior with the marker, the LAO, and the RAO. And her I-123 uptake was 42.6%. So what's her diagnosis? Toxic nodule. She definitely has a toxic nodule. So she has a toxic nodule, but does she have something else? So let's go back and look at her scan. So her TSH is undetectable. And for those of you, because you're all thyroidologists, it sounds like you can hardly see any background. And yet you can see the rest of her thyroid there. Like, think about most of the toxic nodules that you see where you absolutely see no background at all. And so the nuclear medicine doctor said, yes, there's a toxic nodule in the right upper pole, and that's the diagnosis. But we all know that it can't just be diffusely decreased. It should be absent. If someone has a TSH that's absolutely undetectable, you shouldn't see anything. So let me show you her ultrasound. I was waiting for a long time for a case like this because you knew it was going to happen. It's a great case. So if any of you want any of these for your teaching files, I'm happy to send them to you if you email me. So this is her right upper nodule, and you can see it in the sagittal and the transverse view. Sagittal, in case you don't do ultrasound, is another word for longitudinal. You can see it's relatively solid. You can see a little bit of background thyroid here, so it's challenging because we're already going to see the background thyroid is abnormal. So it probably would be considered hypoechoic compared to a normal thyroid, but you're going to see the rest of the thyroid. So there's the nodule that was benign a while ago in the right upper pole. But here's the sagittal view of her right lobe. So you see the nodule on the top, and you see this very heterogeneous thyroid below. And here's her left lobe that looks just like the rest of her right lobe. And you can see that the rest of the thyroid is really quite vascular. And you can see the right nodule on the top here. And here's a nice clip that shows you the nodule, and it shows you the rest of the right lobe, which is very heterogeneous. And her TRAB was 3.2. So what she had then, here's her left lobe, was Graves' disease with an autonomous right upper pole nodule. So you knew it was going to happen at some point, right? You get both of them together, and it's a great case because it makes us all go back and think about the physiology, that if this really is a thyroid nodule causing TSH suppression, you shouldn't see any uptake in the rest of the thyroid. So she got radioiodine, and she did become hypothyroid. Yes, go ahead.
But sometimes when you look at scans, doesn't it happen very often? You have like area of decreased uptake, but then the kind of the area where it diminishes, it's a whole spectrum. Do you always expect to see literally nothing in there?
So it's a really good question. So let's go back to the first case. So the question is, do you expect to see literally nothing? It depends on the TSH. So remember, this patient's TSH was 0.3. So even a TSH of 0.1 or 0.08 is actually enough to cause a little bit of iodine uptake. Her TSH was totally undetectable. So it's a great point, and it's absolutely true that what you'll see in the background thyroid when there might be a functioning nodule or nodules depends upon what the TSH is. And this is a great case for that because the TSH was 0.32, and you can see a little bit of uptake in the background thyroid. And I've seen it even with TSHs of, let's say, 0.08. But hers was undetectable, so there's nothing to stimulate the background thyroid. So the answer to your question is absolutely, you can see some uptake in the background thyroid when there's autonomy, but it depends upon the degree of TSH suppression. Okay. And if we have time, I can escape out of this and pull up other cases if I need to later, right? I'll look later. Okay, so let's go on to the next one. They're just fun cases. Okay, so another case. We're staying, I'll give you, well, I won't give you any hints yet. So a 64-year-old woman whose TSH is normal, and on her ultrasound, she has 2 nodules. She has a left upper pole mixed nodule, TR2, nothing to worry about, and a left lower pole 10 by 9 by 14 millimeter hypoechoic solid nodule with a central linear calcification. So let me show you this nodule. It's actually quite hard to see because there's shadowing and it's really close to her carotid, but the nodule goes around this area, and it was read by the radiologist. So remember, this is a central dense calcification, which actually makes it unclassifiable by the ATA, but by TIRADS, you might read this as hypoechoic, which would give you solid, which would give you 2 points, hypoechoic, which would give you 2 points, a macrocalcification would give you 1 point, so you'd be up to TR4, and then if you said that there were regular margins, that would give you 3 points. So this could be a TR5 nodule. But she was read as having this densely calcified nodule in her left lower pole. And the question was FNA. And what I want to show you is, going back to this, is the evolution of a functioning nodule. So that it's very important, and I haven't seen it written very much in textbooks, that this is actually the long-term sequelae of when you treat an autonomous nodule with radioactive iodine. You get these central calcifications that are really dense, and if you don't get a history from the patient, you can begin to think that something is a suspicious nodule. So let me take you back 12 years to when she was 52 years old. And unfortunately, I don't have her scan, but I think you all know what a scan would look like. She had a left lower pole nodule with suppression of the remaining thyroid, and you can see that she was thyrotoxic. I do have her ultrasound. So her left upper pole nodule was quite small, but her left lower pole nodule was about 2.5 centimeters, and it was functioning. And let me just show you here. You can see the beginning of the calcification over there in the left lower pole nodule, but it's predominantly solid and isoechoic. And like I said, I don't have her scan, but her uptake was 30%, and she was treated with radioactive iodine. And so what happened to her was she got the radioactive iodine in 2006, and you can see by 7 months later, the nodule's already getting smaller. So here, you can see very nicely, this is that nodule before when I showed it to you, and you can see the calcification is there, but not as much. And just to show you, I always say the advantage of being at a place for a long time is you get to follow patients for a long time, so you get to see interesting things. You can see then by 2009, it's getting a little bit harder to see, but you can see a nice view of it here, and you can see it's more calcified. It's deeper in her neck, so it's more difficult to see, but you can see it's getting smaller. By the way, she was euthyroid because the other side of her thyroid was fine. And here it is in 2011, and you can begin to see it's getting more calcified, and it's still even, now it's pretty much at its stable size, and then this is where it is now in January of 2017. So again, the evolution of a functioning nodule that's been treated by radioactive iodine. So getting the history is very, very important. We don't know why these nodules get calcifications. It probably has to do with the inflammation, but really important to get those pictures, because you can see her nodule has been roughly stable in size now since October 2009, but has had increasing calcifications. And I think my nurse practitioner ordered the ultrasound in January 2017, because if you were to ask me why she even needed an ultrasound in January of 2017, she certainly did not. Okay, so another case. So a 60-year-old woman who was feeling fine and had some left ear pain, so you might know where this is going, that was worse a couple of days prior to her presentation. Her physician felt an enlarged thyroid and ordered thyroid function tests. So she's thyrotoxic, and you can see her free T4 is elevated, as is her total T3. And this is her ultrasound. So this is the right lobe. So does anybody want to make any comments about how it looks on ultrasound? Or about the case? This was just read as an area of increased or decreased echogenicity that wasn't read as a discrete nodule. and potentially consistent with, we've seen a lot of viral thyroiditis, but this was the challenge. Because there's her right lobe, but I want to show you her left lobe. So this was her left lobe, and her left lobe was read as having a hypoechoic solid nodule, and you can see it kind of looks pretty discrete on that sagittal view and that transverse view. And it was read as being hypoechoic with some irregular margins. So I think the value of ultrasound is not just to look at the static images, especially in this situation. And it's become, certainly there are some static images that you can look at, and it's very clear cut that something is a thyroid nodule. But I think in this clinical situation where the patient is appearing like she may have viral thyroiditis, yes, you can have viral, I just showed you Graves and a functioning nodule, so you can certainly have viral thyroiditis and a hypoechoic solid nodule. There's no reason why having a nodule prevents you from having viral thyroiditis. But I want to show you, I'll just go right ahead. This was her scintigraphy. So it wasn't that she had viral thyroiditis and a functioning nodule, it was a protectatate scan, and you can see there's no uptake. I want to show you, let me show you this nodule. So her physical exam was very tender, and I want to show you this nodule and the value of looking very carefully. So this is the left upper pole where you can see that there seems to be a discrete demarcation between the hypoechoic area and the isthmus, correct? And remember, thyroiditis can be patchy. And here's the left nodule when you get to the, quote, nodule, when you get to the mid-thyroid. And you can see that the demarcation between this hypoechoic area called a nodule and the isthmus is less sure. And let me show you what it looks like at the inferior pole. So you can pretty much take some areas that are hypoechoic and take a static view and make them look like a nodule. So what I've done here is taken the transverse views, superior, mid, and lower. And certainly if you were to show me that upper view, I would say, wow, that looks like this patient has a pretty hypoechoic solid nodule. If you were to show me the mid view, I'd be more towards some sort of diffuse process. And certainly by the lower view, I'd say, you know, I need to see more to figure this out. And I think that's the value of real-time clips. So what I'm going to do here is show you the clip, and this should hopefully replay, but notice as you come lower. Up at top, it's more discrete, but as you come lower, it really blends in. Are you able to see that? So this was all viral thyroiditis. And so just to remind you that viral thyroiditis can be, and here's her ESR, and viral thyroiditis, you know, certainly the right side looked pretty typical for viral thyroiditis, where there was just a more hypoechoic area. But this left side, you really have to look at the nodule or the area labeled as a nodule in all of its planes, because just to take you back to this original picture, this is I would look at this, and I've seen so many of these. If you just show me this ultrasound, I would ask if this patient had viral thyroiditis. What makes me think it's viral thyroiditis and not Hashimoto's? Because there's this one hypoechoic area alone, and the rest of the thyroid looks normal. In Hashimoto's, where it can be patchy, there's going to be multiple hypoechoic areas. There are also these irregular, ill-defined borders. And in Hashimoto's, when there's hypoechoic areas, the border tends to be more defined. So if I were to even look at this ultrasound and someone would say, give me a differential of this ultrasound, I would say viral thyroiditis, viral thyroiditis, viral thyroiditis, weird Hashimoto's. And then when you look at the other side, this is hard, because if you just showed me these static images, I would say, yeah, it looks like a nodule, but it really, I mean, here it definitely looks like a nodule, so it's only with the value of looking at it on all different transverse views and the clip that you can see the difference. And so I think it really, and that's why we as endocrinologists, if you aren't doing ultrasound or you're not working with a radiologist who saves clips, and that's all you're given, the only way you can potentially think it's not a nodule is if you examine the patient and it's very tender, so that would give you a clue.
What is this white crescent? Is that some calcification?
No, the white crescent there, so what you're asking about is that white up there. It's probably just the interface between where the nodule is and the thyroid. It's not, if it were calcifications, there'd be shadowing. And so let me just show you though, if you were to biopsy her. I did not biopsy her, but what you would, so let's say, what's the worst possible case? You biopsy the patient, And I have no idea, this is from a textbook, because I haven't biopsied viral thyroiditis, but it's a very small one. And I do actually have a viral thyroiditis that presented once as a very small nodule, and we watched it evolve over a period of 3 months until it occupied the entire thyroid. But what you would get if you biopsied are these cells, which are actually multinucleated giant cells. You get histiocytes and granulomas, and then you can get a small number of proliferative thyroid cells. So your cytologist should be able to tell you. There's very few things on cytology that will give you a multinucleated giant cell or the histiocyte granulomas that it's viral thyroiditis. And I think, David, you're going to show Dr. DeQuivain, right? So I'm going to skip this slide. Okay, so here's another case. So here is a 34-year woman with a 2.8 centimeter left thyroid nodule, no right thyroid nodules, normal lymph nodes, and a TSH of 1. We finally have a normal TSH. And here's the Doppler. So since you all do ultrasound, what's the TI-RADS classification for this? How would you describe it? Is it hypoechoic? Yes? So hypoechoic solid, so that's 4 points, smooth margins. Yeah, no calcifications. So it'd be a TR4 nodule, ATA intermediate suspicion. It's TI-RADS would biopsy it at 1.5 centimeters, ATA at 1 centimeter, so the recommendation is for biopsy. Okay, totally great. And that's what it looks like. Here it is here, just so you can see. I always like clips. They show you a lot. Okay, so we just described the nodule, so we biopsied it. Okay, so here's the biopsy. Actually, I didn't biopsy it, the radiologist biopsied it. But I could have biopsied it just as well. Okay, so it came back as Bethesda 4, which is follicular neoplasm. It actually had oncocytic features to it, so there was more cytoplasm. So what would you do with that? Lobectomy. So basically here, in the absence of molecular testing, a lobectomy. So it's a hypoechoic solid nodule with Bethesda 4 cytology, and you'll hear in my talk tomorrow that ultrasound can inform malignancy risk based upon cytology. So the malignancy risk of this nodule is probably about 35 to 40%, and certainly in the absence of molecular testing, a diagnostic lobectomy would be what's done. You don't repeat the cytology for Bethesda 4 of something of this size. We actually have molecular testing available. So this was all done. I met her after all of this happened. So in February 2018, she actually went back to have an FNA for molecular testing, and there was insufficient material. And then she had another ultrasound in May 2018, and sort of looking a little smaller there, still hypoechoic. And they biopsied it. And I want you to notice that where they biopsied was they went on the outside in the capsule, because they were trying to see, this radiologist did it, they were trying to see if there were any viable follicular cells here. But all they got were macrophages and debris and no follicular cells. So 5 months earlier, she had a Bethesda 4 cytology. Then 2 months later, she had an FNA for molecular testing that was non-diagnostic. And then they tried to get something again, and they got no follicular cells. So this is what this nodule now looks like in June 2018. It's 8 by 10 by 15 millimeters, 0.8 by 1.0 by 1.5 centimeters, a predominantly cystic nodule. It's much smaller, and it's totally avascular. And you can see even here, moving, looking carefully, try to play this again. With Doppler, you can see there's nowhere, even in the periphery, where there's any vascularity. And this is what it looked like in November of 2017. So it was solid, it was hypoechoic, it's vascular, it's now mostly cystic. And it's gotten even smaller. In December 2018, it's now down to 11 millimeters, and it's predominantly cystic, and it is avascular, and here it is again. So what happened here? Have any of you seen this happen? We wish we could patent this. This is without microwave ablation. This is post-FNA infarction. And this generally happens, it's pretty rare. It happens in less than 1 in 300 FNAs, but it generally always happens with oncocytic cells. Because if you remember, like, why does Hurdle cell cancer respond so well to the kinase inhibitors? Mostly because there's so much vascularity, and the kinase inhibitors are multi-kinase inhibitors that target VEGF. So it's these oncocytic tumors that are so vascular that for some reason, I don't know what blood vessel they hit, but it's very, very rare. It's most commonly described in Hurdle cell neoplasms, FNs, oncocytics, because they're so vascular. Often what happens is we biopsy them, we get the cytology, and they actually go to surgery 2 months later. You never see the ultrasound again, and the pathology comes back that the nodule is 70% reduced in size and there were no viable cells and it was sclerotic. And it can even be, and then the pathologist will say, we can't tell you if this was a Hurdle cell cancer or a Hurdle cell adenoma. So it's actually interesting. People have studied the patterns of necrosis that can occur. So you can have central necrosis with a viable periphery, which is actually what we were trying to see if she had in that last biopsy. You can have sort of a wedge-shaped necrosis, or what she actually had was total necrosis. And this is what they tend to look like if you do take them out. You just have inflammatory tissue, and occasionally, you will have a rim of tumor at the residual edge. So I probably have about 5 to 10 of these people that I've followed over time. And I do ultrasounds because I figure if there's any viable tissue left, it's going to grow. And that could be something we need to be worried about. It's sort of like I did my own microwave ablation, but I didn't. And actually, none of them have grown. And most of them have stayed. They're all about 1.1 centimeters or less. And some of them are on ultrasounds every 2 years at this point. But again, something to know that can happen. And there's no reason at this point to go in and take out this tumor because whatever you've done sort of the equivalent of a microwave ablation procedure, but there's nothing left. So just to remember that this can happen. Okay. Do I have any pediatricians in here for a 12-year-old boy? None. Okay. So here's a 12-year-old boy who was referred to you after a pediatrician ordered a thyroid ultrasound for a palpable goiter. But when you look at the ultrasound, you will see that his thyroid is normal, as was your thyroid examination. And his TSH is 1.9. And so on his ultrasound, he was read as having a left hypoechoic nodule with echogenic foci. So we can see the left lobe of the thyroid here, and you can see the nodule there. Do you all see that? Okay. Let me show you the sagittal view. So there's the nodule. Can you see it? It looks sort of hypoechoic, but it's kind of strange because it has these sort of more globular echogenic foci. It's solid, so I wouldn't really consider it spongiform, and they're not linear, because we talked about how the echogenic foci in a spongiform nodule can look linear. So a clue is his age. Does anybody know what this is? His clue is pediatrician. Does anybody know what this is coming up from his mediastinum that actually is attached to it over here? His thymus. So intrathyroidal thymus is actually something that you can see, and believe it or not, our pediatric endocrinologist about 6 months ago presented a case where a 6 or 7-year-old boy was ultrasounded in Los Angeles and had something that looked like this, and they told him it was cancer, and they read that there was a thyroid center at the Children's Hospital of Philadelphia. So they came for a biopsy, and it was intrathyroidal thymus. So this is intrathyroidal thymus. Not something we see very much as adults, but it's important. In fact, I've never seen it in an adult. But it's important to know about because you have to remember the thymus is actually not a midline structure. The thymus actually arises from the 3rd and 4th pharyngeal pouches and has to migrate down into the thorax by the 8th week of gestation. And so you can have ectopic thymus tissue all along the pathway of descent. And so it's generally totally asymptomatic. As an adult endocrinologist who takes care of patients with thyroid cancer, as I'm sure David Cooper has seen as well, it's not uncommon. Like we see all the time. In fact, in people up to the age of 50, when I've been doing a chest CT to look for lung metastases, you can see the thymus it's in the eutopic position, but the thymus does not regress in every single person over the age of 25. And we've also seen cervical thymus extending up into the lower level 6 area, and so in adults, after radioactive iodine, sometimes labeled as metastatic lymph nodes because it has those bright little areas in it. And actually, it's great because now we actually have a prospective study. So as you all know, after the tragedy in Fukushima with the tsunami that also affected this country, very tragic, wrong tsunami, which I didn't realize here. The tsunami here, which was Indonesia, which I didn't realize till I was in Gaul, how much was affected here as well. But the tsunami that affected the nuclear reactor in Fukushima, there's a very robust screening program that's going on. And so actually the Japanese have now screened almost 38,000 children, and they actually have found the thymus in 1%. So we never really had prospective data about how common it was to find intrathyroidal thymus, but now we do. The mean age is usually around 7, and it's equally located in both lobes. So it's going to be either in the right or left lobe. And I think what's especially nice about this particular picture is you can see the thymus that's coming up from the mediastinum below, and then you see the intrathyroidal thymus. And then to play this for you again, you can see the thymus is sort of, it's going to either be, the intrathyroidal thymus is going to be round or oval or polygonal. And we're going to talk about these punctate echogenic foci. But if you look on this clip, you can actually now see the connection now that you know what this is. Now, a lot of the ones that I've seen, which have been when our pediatric colleagues have presented them to us, they have not shown that connection. They're pinched off in the thyroid. They regress with age, the way the thymus itself gets smaller. But these bright areas are, there's the thymus, and there's the intrathyroidal thymus, are Hassel's corpuscles. So we think, so to remember Hassel's corpuscles, nobody knows what they're doing in the thymus, but they're there. We think that it's the Hassel's corpuscles, which this sort of concentric lamination of protein are what's causing these bright areas, and that's what you're seeing. So for the adult endocrinologist, if you follow patients with thyroid cancer, you may sometimes see the thymus coming up from the mediastinum, and it may sometimes look like an abnormal lymph node, but you'll see the flame-shaped structure, and you'll realize that you don't see the inferior border, and it will look just like the bottom there. Okay. 58-year-old man. Abdominal CAT scan detected a left lower pole nodule in his lungs. So then he had to get a chest CT that showed that it was the ground glass. And then the chest CT found the thyroid nodule. Isn't this a pretty common story? And that led to the thyroid ultrasound. So this is his nodule. Now, you asked me about white lines. This is a great one for that. So this is a 12 by 16 by 24 millimeter left upper pole solid hypocoat nodule. They read internal curvilinear calcifications, and I'll show you the vascularity. I don't know what that white line is, but it's not a calcification because there's no shadowing. So you can't have, so it's some sort of fibrosis, but it's a really important point to point out that this can't be a calcification, because if this were, this would have all the shadowing that I showed you on one of those earlier nodules. But it's definitely hypoechoic. It's definitely solid, and here we go. Here's the clip, and it's sort of funny. It almost looks like, in fact, when I looked at this, it's one of my patients, it's like, what is that? Like inside its thyroid, this almost looks like a little, you know, like we're doing ultrasounds of the placenta, like there's a little embryo right there. But this was solid. Let me show you this. Here's the vascularity. It wasn't cystic. It was solid, and this is what it looked like. So how would you classify this? I think that even TIRADs would have, it's certainly hypoechoic and solid. It seems to have smooth margins, but even TIRADs can't categorize that white line that's not a calcification, but that would at least give it TIRADs 4, and certainly it would meet biopsy criteria. So the question was FNA. And so now let me give you more history. The reason he had the abdominal CT was that he had recurrent kidney stones. And these were his blood test results. His calcium was 11.4, which was elevated. His PTH was elevated, and his 24 urine calcium was elevated as well. And he actually had a sestamivi done with SPECT CT, and his 2.5-hour delayed imaging with sestamibbe showed a nodule in the left upper pole of the thyroid. And we know that thyroid nodules can be there as well, but this could then be an intrathyroidal parathyroid. So intrathyroidal parathyroids are not very common. It's less than 2% of all parathyroid adenomas. This would have to be an upper pole parathyroid because the lower pole parathyroids are much less likely to be intrathyroidal. And the usual location of the upper pole parathyroid, if it's not intrathyroidal, is about 1 centimeter over superior to the inferior thyroidal artery. So I'm going to show you, this is not him. This is a typical superior parathyroid. So here's the sagittal view. And some people think that the superior parathyroid is supposed to be superior to the lobe on the left. It's not. It's posterior to the mid-thyroid. The inferior parathyroid is below the thyroid, but the superior parathyroid in the eutopic location is right in the mid-thyroid. And you can see here as well, it's nicely on the transverse image, it's lifting up the thyroid. It has to like lift it up and the thyroid drapes over it. They're generally hypoechoic. And let me show you a clip of it right here. You can see very nicely there's a little cystic nodule right there. This is not this patient. This is just a typical upper pole parathyroid adenoma. And let me show you this. So here's the inferior thyroidal artery, and this is the typical location right over here. So he just happened to have an intrathyroidal parathyroid adenoma. Now, if you didn't know that he was hyperparathyroid, let's say someone just said to you, here's a nodule, the TSH is 1, and that's his thyroid, you would biopsy it. Does anybody know what parathyroid cells look like on cytology? They often get read as, well, they're certainly neoplasms, and they generally have a lot of cytoplasm, so often they're read as Bethesda 4 or follicular neoplasm. And it's really, the pathologist can stain for PTH. They have abundant cytoplasm, but it's really our job to tell the pathologist that someone is hyperparathyroid. And generally then, they will be able to make a cytology diagnosis, or you can do a rinse for parathyroid hormone. In this case, there was no reason to biopsy that because we had the sestamibbe that showed that this was his parathyroid. I have plenty of other cases. Just have to ask AV if they can you unhide my slides? Because I have other cases, because we have I had no idea how long this would take. I did wanted to show you, by the way, for those of you who've seen Rocky, this is Philadelphia, and that's Rocky from the steps of the Philadelphia Art Museum. I've been showing pictures of Philadelphia all day today. But can you unhide my slides, or can I do that? I can do it from here? Perfect. Okay, so let's stick on the parathyroids a second. Okay, so this is, are you able to let me show the rest of my slides? Or I have to go let me do this. Are you able to, do I have control of it, or do you have control of it? Can you just unhide the next 10 slides? Is that possible, or do I have to do it from here? Do you want me to do it from here? Here, I can just do it. Hold on. But, okay, they were able to do, can you just unhide the next? I can do, if you just let me have control back, I can do it. Okay, so I want to stick on the parathyroid theme then. Can I have controls? They're not letting me have control. Either they can do it or I can do it. I'm happy to do it. Okay, perfect. Okay, so let's go back a sec. Okay, so let me show you. This is one that I found very challenging. So this was a patient that was read as having a left lower pole parathyroid. And this is the static image of her nodule. And she actually had a bunch of nodules. So if you look here, she had 2 nodules, one in the left upper pole and left mid pole, that are both hypoechoic and solid. And that one kind of looks the same. And actually, and it almost, to me, remember I told you how it generally, the parathyroid will pick up the thyroid. So my radiologist and I had a discussion about whether this was lifted and draped over the nodule or not. And I think what was really important, this patient was actually initially labeled as having 3 nodules on the left and was sent for biopsy. And I was looking at her ultrasound to decide which nodule to biopsy, and that's when we had this discussion about whether this nodule was a parathyroid. And you can see, though, when you look at it carefully, it's not quite doing the pickup of the thyroid. Like the thyroid comes around it more like a claw. And so this would be something that would be more suggestive of something that's intrathyroidal. I'll show you some pictures. So here's a clip of this. And I want you to notice that as it comes back, you can see that as you move forward and back in this nodule, you can see that it's clearly, it looks like it's within the thyroid. And it also shows the advantage of having the real-time clip, like right here. You can see that this is actually not extrathyroidal, and this actually was a thyroid nodule. So let me show you what a lower pole parathyroid looks like. And here you can see very nicely, here's the inferior pole of the thyroid, and then here's the parathyroid. And if you look at the interface between the thyroid and the parathyroid, it lifts it up more. It's not that it comes around it. And that's one of the clues when you look at that interface, if something is actually extrathyroidal or intrathyroidal. So the typical location of the lower pole parathyroid is generally a centimeter below the inferior thyroidal artery and below the lower pole. And here you can see nicely the inferior thyroidal artery, and you can see the parathyroid just below it. So a little bit different. And one more clip of this inferior parathyroid, which I think you can see here really nicely. So I think this case really illustrates the importance and the thyroiditis of the real-time imaging. Okay. So a 36-year-old with fullness in the neck and this big black thing right there. Is this cyst fluid or solid? It's a cyst, and it's inferior to the thyroid, and it extends to the midline. And again, you see this nice, you can see it's extrathyroidal. There's this nice picking up of the thyroid. It's not that the thyroid comes around it. It's lifted up by this area here. So this is a cyst that's inferior to the thyroid, and it actually extends to the midline. So if we look at the clip here, you can see the thyroid, and then coming down, there's this large cyst. So I had never seen anything like this before. I've seen parathyroid cysts. Has anybody ever biopsied a parathyroid cyst? Never. Okay, so clinical pearl. A parathyroid cyst is generally the inferior parathyroid, so it would be a pure cyst below the thyroid. When you stick a needle in, it's the only time that you'll get back clear fluid that looks like water. So if you ever stick a needle in and you get fluid that is truly crystal clear like water, send it for parathyroid, and that's generally a parathyroid cyst. This was not. We FNA'd it, and we got back white fluid that was very milky, where the triglycerides were very elevated. And this is the lymphangioma, which is now called a lymphatic malformation. These are actually congenital malformations. Again, something the pediatricians see a lot more commonly because the way lymphatic tissue develops is there can be sequestration of lymphatic tissue, and so it doesn't communicate with the rest of the lymphatic venous system, and you can get dilatation. So it generally is congenital. It can also happen in some of our patients who've had radiation therapy or trauma. This patient was totally healthy and had none of that, and it was probably just congenital and somehow appeared. They're generally multicystic. This was a unilocular cyst. It really bothered her. It was huge. And she actually just had it removed, and it was lymphatic malformation, and she's fine. But again, we can send our fluid for lots of things. We can send it for parathyroid hormone. If you see white stuff, it's usually the thoracic, it's usually lymphatic fluid. For those of you who do thyroid cancer, another clinical pearl is, as you know, the thoracic duct is on the left side. So sometimes, especially after someone's had a left neck dissection, you can get dilatation of the thoracic duct, and it can almost look like a cystic lymph node. But if you stick the needle in to try to drain it, you get white fluid, and so you know that it's a dilatation of the thoracic duct. So I've certainly biopsied things related to the thoracic duct before, but in the setting of thyroid cancer and prior surgery, not for a lymphatic malformation. Okay. So we have a little bit more time, and I have some other pretty cool cases that go along with what David said, just to drive home the point about some micronodules. So this is a 62-year-old man. Ultrasound was ordered to evaluate fullness in his neck, although when you examine him, his thyroid is absolutely normal in size. And his TSH was normal. He has no family history of thyroid disease. And this is his nodule. So he has a nodule and this is an example of shadowing. So David, you were able to get the pointer on this, right? Laser pointer. Yeah, there it is. Okay, so can you see the shadowing back here? You were asking me about white with shadowing. So this is shadowing. So you can see very nicely here the shadowing, because this is a central calcification, but the nodule is hypoechoic. It has infiltrative borders. This is actually the type of nodule that you can leave alone, because the shadowing makes it look like it's against the posterior capsule, but it's not. That's just the shadowing of the nodule. So this is the type of nodule that I look at and I say this is probably thyroid cancer, but it's very, very small. And here it is here. And let me go back to the slide. There, sorry. So solid with shadowing calcifications, and follow-up is recommended because there are no abnormal lymph nodes and it's stuck right in the middle. So it's exactly what David showed you, the type of microcancer that can be followed. And that's what was done. And let me get rid of this. So here it is in May 2013. It's absolutely stable in size. Here it is in April 2014. It's absolutely stable in size. Here it is in April 2015. We're still following this nodule because it's very small, and the recommendations are an ultrasound every year. And here it is in March 2017. And somehow, one of the radiologists, although they started to use TIRADS, recommended an FNA. After, in the past, they had been following it, but like I said, it was a different radiologist who hadn't followed guidelines, and this was FNA'd. His primary care doctor seemed to not realize he was being followed. It was FNA'd, and it was papillary cancer. And I think before we could get a hold of him, he actually ended up with surgery. And I think David went over all the microcancers very well, but I wanted to take this time to show you this. So besides what he went over, there's some ultrasound predictors. We know that microcancers are more likely to grow in younger people than older people, but actually this is a really wonderful paper from Japan that talked about the ultrasound pattern of the nodules and how ultrasound pattern can determine growth rate. So our patient would have been categorized here with dense calcifications. This would be rim calcification, micro, and none. And if you think about it, it kind of makes sense, because the more calcifications are present, the less viable tissue. So that if you just have a micropapillary carcinoma that's non-calcified, those are more likely to grow, and the more calcified they are, the less likely they are to grow. So another factor to put in, clearly, you know, said we'd be more aggressive potentially in a younger patient than an older patient, but the sonographic appearance of the micropapillary carcinoma can be predictive as well. And I would tell you, in my experience, most of them generally tend to look like this, probably because we recognize them the most easily. And the ones that grow, we're going to talk about those, tend to look like this. So, to throw some of those in, I'm going to show you now some real cases of growing micronodules. Now, David just told you that most of the time they don't grow, so I'm going to show you the exceptions. So this is a lovely 53-year-old woman who had this beautiful spongiform nodule, and actually a nice example again of a dense calcification in the spongiform nodule, which doesn't change risk, but you can see the shadowing. Beautiful spongiform nodule. It was biopsied. It was Bethesda 2. And that was in 2014, and we said, fine, you're fine, you don't need anything. But her internist, 4 years later, did an ultrasound, and they said, yeah, the nodule you biopsied was fine, but look at her right mid-nodule. So this would be one of those nodules that is hypoechoic solid. It definitely has infiltrated margins and is non-calcified. So going back to that ultrasound paper, this would be one of those nodules that could grow. And I said, what? Like 2019, what did this look like in 2000? This is definitely high suspicion. And you can see it's not vascular. And here it was in 2014, because we went back and we looked at it. So here it was, and look at it right here. It has that exact same pattern. It's hypoechoic, it's solid, has infiltrated margins. So one of the issues is that by new TARAs and even by ATA, we would never follow this. Like, this is something that it's sub 5 millimeters. This would never be followed, but now it looks like this. And this just happened like 2 or 3 weeks ago, so I'm about to biopsy it, but it's going to be papillary thyroid cancer. So, and what would lead me to biopsy it now? You could say that you're going to wait for it to grow. So obviously, if this were the first, so this is where guidelines are just for general guidance. If this were the first ultrasound I had ever done, I might not biopsy it. But now I have that this thing has probably gone up. If you do the volume, it's gone up about 8 to 9 times in volume over these 5 years, and so we probably will biopsy it. We're going to talk about it. But I think, again, I think it's a micronodule that you can follow and you can find. So we'll go over here. Oh, sorry, this one we did. I apologize because I hadn't put this in. I did biopsy it, and this ended up being a medullary cancer. So I did biopsy it after talking to her, and this was a micromedullary cancer. She had no family history, RET was negative, no C-cell hyperplasia. Pretty bizarre case, yes?
My question is, anytime there's an invasion of the capsule, what is your threshold where you say, I need to do biopsy on this nodule in terms of size of the nodule versus saying, well, let me do ultrasound? Because in this case, there was invasion of the capsule, I believe, in the very first ultrasound you showed us. Is that right?
No, it wasn't invasion. It was the shadowing of the calcification. There was no invasion in the capsule. You have to look at the clip. So one of the questions is, how good is ultrasound at predicting capsular invasion? And there's actually some studies on this. And the nodule has to be abutting the capsule by at least 50% of that circumference, because otherwise ultrasound isn't very good at predicting invasion in the posterior part. In the anterior part, you can more easily see it because you can see the interruption of the capsule. So it really ultrasound's not very good at predicting posterior invasion. But that was a micromedullary. And then just one more, because I have, here it is here. So again, the micronodules that grow. So a 61-year-old woman with a multinodular goiter and a left mid 7 by 9 by 10 millimeter nodule. Like, for example, you can see here very nicely the continuation and the lack of invasion in the anterior capsule. But it's hypoechoic, and it has infiltrative margins. It was read as high suspicion. It's right, again, next to a spongiform nodule. And this one, I'm going to go back further. So 10 years before, it was 3 millimeters. Remember, I told you I've been following patients a long time. So in 2015, there it was. In 2005, it was 3 millimeters. In 2007, they retrospectively measured it, and unfortunately, I couldn't get those off, but it was 4 by 5 millimeters. I'll keep it up there. In 2010, it was 4 by 5 by 6 millimeters. In 2012, you can see it here. And in 2015, it was here. So again, some micronodules do grow, but the majority don't. So just be on the lookout for them. And I think these two show very nicely the fact that it's the hypoechoic solid nodules without calcifications that are more likely to grow. So with that, why don't I leave the last part for questions or a break before Dr. Cooper starts. And thank you for your attention and for looking at lots of ultrasound images.